Father, we thank Thee again for today. We thank Thee for the progress of yesterday. And we please pray to Thee to be with us, guide us for a fruitful session today. In Jesus Christ's name I pray.
Amen.
Thank you very much, Daddy Pastor. Let's have our seat, please. Very shortly, we'll be taking a presentation from the team of Genesis Specialist Hospital. And before we do that, we'll have a brief recap of what happened yesterday. Yesterday was the opening ceremony. To God be the glory. We embraced the presence of His Excellency, the Governor of Lagos State, ably represented by the fresh Commissioner of Health, Professor Akin Abayomi, the Speaker of the Lagos State House of Assembly, Right Honorable Mudashiru Obasa. They were on ground. It was a very successful outing. The keynote lecture on caring for the who cares for the carer was delivered by Dr. Ayoade Adelekun.
Who wants coffee?
If I can say good day, ladies and gentlemen. While you are enjoying your tea, let me introduce this interesting topic. Actually, we are going to be discussing this time around not so much as doctors but as persons. There is a rule of thumb. The only exit from aging is death. That's the only exit. So if somebody wishes not to age, what it means is that you may be wishing for an early exit. The truth is that with improvement in healthcare delivery, people are growing older. People are living longer. Maybe not in the parts of the world where we are having conflict, but in areas in the world where it's unreasonable peace. Because the improvement in health services is a global thing. It's not restricted to a particular place. Even though in some parts of the world, it's better than others. So with that, people are growing older. What that means is that any reasonable establishment or society must prepare to care for those that are going to grow old. So the attention should no longer be on maternal and child health only. There must be attention on geriatric health, because those that are going to take care of those children are going to age. And the prayer that is done for those kids on their birthday or their day of birth is that if it's Yoruba, they will say Wago, Wato, Wadaka. Now, whether that's a prayer or a curse, but the fact is that once you have plans to age, which is what I'm sure most people are here have that hidden agenda, then there must also be a plan to manage the consequences of aging. Now, how do you define aging? The truth is that on a daily basis, people are going to age. So if you talk about those of us that are really young in this environment, that are really young in this city, maybe we have people who are 30, 40 that I can see here, even those of them have gray hair. Once you are aging, it means that compared to yesterday, you have aged. It's a relative term. But in real terms, when they're talking about people who are aged, they're talking about people who are about to exit the Middle Ages. and get into the real age of the citizens or the senior citizens, that's 60s. Now, what is the relationship between low back pain, spondylosis, which is a term that is loosely used, and aging? Now, first of all, what is implication? When you say people age, what exactly does it mean? What it means is that you have cells that are being that are wearing out, that are being destroyed. You have molecular changes, and those changes are at micro levels, but at macro level is going to reflect in your whole being. Albeit the rate at which it's going to reflect is not linear. It differs from person to person. When you say it's not linear, what it means is that if you get to some parts of the world, a 70-year-old looks like a 40-year-old in other parts of the world. Now, within the same environment, maybe on the same street that you grew up, you will know somebody who is far younger than you are, but circumstance of life or circumstance of lifestyle has made him look older than you are. So that's why they say it's not linear. If it were linear, I would be able to predict people's ages that are here. But I can assure you there are some gentlemen and ladies here who are reasonably older, but looking younger. Now, what are the consequences of aging? The consequences of aging is not far-fetched from anybody. It's not the textbook stuff. If each person that is here look at him or herself, in fairness, I'm not saying we should announce, but be fair to yourself. You can see consequences of age. For those of us that are really young, we have gray hair. Yeah, I know what earlier I said it's a relative term. There are people I know here that are far older than I am. And some of them are even looking younger than I look. You know, but hair changes, hair loss is one of the consequences of aging. That it can't be denied. As you grow older, you tend to forget more. Your rate of synthesizing and analyzing information will be slower. So you find some of us, we get home, you want to use a remote control, you call the 5-year-olds, come, help me do this thing. Because those things are changing, and they're changing really fast. I mean, I'm sure there are gentlemen here who have had cataract surgery, or those who are about to have. There are gentlemen here who 20 years ago were not wearing glasses, and today they are wearing readers or variants, so there are visual changes. And there are gentlemen and ladies here who need louder noises to hear better. Those are some of the consequences of aging. The heart muscles are going to get thicker. The blood vessel walls are going to get thicker. The blood pressures are going to go higher. If we take a census of gentlemen and ladies that are here, I wager that half are on antihypertensives. Not only because of age, but because they are doctors. The GIT, slower constipation, the genitourinary system. The gentlemen that are here know what I'm talking about. Someone said something. I didn't say anything. Then, in terms of sexuality, a few changes are here, there, and here, and there. There are a few gentlemen here who are PDEs. Sir, you didn't say anything. But I'm sure you understand what I'm talking about. Your muscles are not as tough as they were. They are becoming flabby. Your tendons are not as supple as they were. Now, if you take a high jump, you will take analgesics at night. If you try what your son tries, you will actually take some things at night. Now, the last three are the ones that really concern this discussion. They are going to be bone changes, changes in the joints, and changes in the spine. Now, before, the commonest change, which was what the spondylosis that is there, it just implies degenerative changes of the spine. But let's talk about people who tend to ignore the non-degenerative changes in the spine that come often with aging. So I'll start with those ones. There are two common ones that we find. Anywhere in the world, the two commonest non-degenerative changes in the spine that you're going to find are osteoporosis and spine tumors. I'm going to start with osteoporosis. Osteoporosis was a major issue in the last decade, because it was a decade of bone and joint, attend an orthopedic or family medicine conference in the United States, and it will not be a topic of discussion. The reason is that osteoporosis will come, but if you start early, it can be mitigated, and its consequences in the spine can be very, very, so that it comes at a later age. The pictures depict that of a normal bone and that of an osteoporotic bone. The current truth is that the bone is a store for minerals, for mineral deposition. Now, what we fail to note is that is what you keep there that you are going to find there. During the stage of growth, of rapid growth in a child, when his bone turnover is more of deposition than, I will call it destruction, more of osteogenesis than osteoclasis. At that stage, you have a net growth in bone. Once it plateaus around the age of 18 and 25, then you have the net is still positive, but it's not as positive as it was, because now you are no longer growing. Now what you are doing is you are depositing bone. Now from the age of 25, 30, the bone turnover starts tilting. It's the men that are not in the way I don't know. Maybe it's because it's called menopause. Now, at that stage, the hormonal changes will now turn towards bone loss. So if you don't have a good bone stock, your bone loss rather, will be so much more, the impact of bone loss will be more felt. Now what happens to a lot of people is that you start having microfractures. But people don't know. They just come here, I'm having bone pain. Every time, bone is just paining me. But you start having microfractures. Now, when the bone loss gets to a stage where the bone is basically just a shell, then it's going to the fracture is now going to become macro. Now let's now talk about the spine. You can imagine the structure of the spine, keeping and protecting your spinal cord and nerves, maintaining your structure. At your L4, L5, it's carrying practically the weight of your head and your torso. Then if that bone collapses at that time, the consequences are way beyond just bone collapse. The consequences now become neurologic. It becomes nerves, possibly paralysis, and we see that often in our environment. We do see that. We see that. These are the consequences. We see it in our environment. But this is one of the most preventable types or causes of bone pain. Prevention in the United States, in the past, what we thought was that give them calcium and you solve the problem. But recently it's been discovered that no, calcium won't stay. Or give them vitamin D3, then calcium will stay. If you give them calcium and you don't give a heavy dose of D3, then calcium will just pass through. The blood will tell calcium that, look, I have enough in the blood system. And it will just pass through, it will just go. But when you have vitamin D3, it will move your calcium, keep it in bone for you, and when you swallow calcium, it will now go into blood. So you will now encourage storage. Now in the United States, they encourage women to take as much as 5,000 national units of vitamin D3 almost on a daily basis, especially women who are perimenopausal. Yes, thank you very much. Now, this, let me not go into the management. The next thing I want to talk about regarding non-degenerative back pain is tumors. Now, spinal tumors are not common. I'm talking about structural spine tumors now, because I can see Mr. Ojo here, so that it does not call my statement to order. They are not common in the younger age group. They are commoner in middle age and in those who are what I would call elderly, in quotes. Now, the unfortunate aspect of it is that more often than not, they report to the spine from other sources. So it's not one issue, it's now a double issue. It's a tumor coming from somewhere, now reporting to the spine, or what I would call metastasis to the spine, and now causing weakness in the spine that will eventually result in fracture. Its presence in the spine alone will cause back pain. If it causes a fracture, that will also cause back pain, makes it worse. Now, these conditions, towards the end, we are going to discuss whether it has to get to that stage before they are discovered. Now, that's an example of spine metastatic tumor. Now, let's now come to degenerative spine, which is the so-called spondylosis. Spondylosis, as a term, is often loosely used by many people. It's often loosely used. Spondylosis is more than just degeneration of the disc. It is degeneration of the disc and the consequences of that degeneration. So instead of us to call it degenerative disc, spondylosis is degenerative disc disease. It's plain disease. Now, it starts early than people think it starts. The causes of spondylosis starts at maybe at the age of 20, when you have issues between the nucleus pulposus and the annulus fibrosus in the disc. Loss of water. The disc, by its design, is a shock absorber, and its responsibility is to take water when you are standing and release that water when you sit, because it's when you sit that you do axial loading. That's its responsibility. So it does this work for a very long time. It does it so many times in a day that you don't have count of how many more times that it does it. But you have genetic factors where disc is concerned, in terms of the I want to use the word strength of your disc in quotes. Then we have lifestyle. We have disc loading lifestyle. I tell people that, look, if you are somebody who stands more than somebody who sits, it means that your disc loading cycle is less than somebody who sits. Somebody who sits for 2 to 3 hours, what you have done is that you have kept your disc desiccated for that duration. Until you stand, then it imbibes water. But when you sit for long, you are likely to accelerate the degeneration of your disc than somebody who sits and stands. So much so that if you talk to the rehab people now, they will say, for every 15 minutes of sit, take 1 or 2 minutes of stand, so that you allow the disc that has extruded water to imbibe water again. That's one. 2 is that cycle itself wears out with time. Now, if you load your disc with, say, 40 kg, and somebody else loads his disc with, say, 400 kg, of course, the 400 kg disc is going to wear out faster than the disc that carries just 40 kg. So there comes the issue of lifestyle. Now, a spine segment, which is a vertebra or another, has 3 joints. We call it the 3-joint complex. The joint that is in front, which is the joint of the disc. The joint that is behind, which is the joint of the facet joint. Now, as the joint of the disc starts wearing thin, its impact is that the joint of the facet joint starts becoming unstable. And you can imagine, between the cervical spine alone, you have like 8 facet joints on both sides. In the thoracic spine, you have like 11 on both sides. In the lumbar spine, you have like 5 on both sides. Now, all those joints are like small knee joints. There's nothing in the knee joint that they don't have. The knee joint has capsule, they have capsules. They have cartilage, they have cartilage. So as this joint starts wearing out, and they are the ones that maintain your structure when you stand, otherwise the disc will roll you forward. As this joint starts wearing out, they start becoming more painful. Now, for the average person at the age of 50 or around 50, you develop facet joint pain. It's classical. You wake up in the morning, you are standing up in pain. After walking around your house a little, it's like you have forgotten about it. That is an introduction. That's introduction. After a few years, then you require like 30 minutes of walking around before the pain goes away. After a while, every time you sit, to stand is a painful process. So it's getting closer. as time goes on, it starts getting larger, and it now starts disturbing the nerve root that is passing right under it, and it starts giving you nerve root signals. So it's a very important joint, but in itself, with degeneration, back pain, like they say, most people will get there if they live long enough, arthritis. Those osteophytes will also disturb those nerve roots. Now, those are facet joints at the back. Those are the facet joints there. That is an arthritic facet joint. And once it's large, it will disturb the nerve root. By itself, it will generate pain. Now, there are other conditions that affect the spine in non-aging persons that does not spare the aging. If there is trauma affecting the spine in a non-aging person, trauma can also affect the spine in somebody who is aging, causing pain. Ditto infections. In our environment, spine infection is becoming common. It's becoming commoner. Not necessarily from intervention, but also from urinary tract infections, from poor immunity, from immunosuppression, and all that. It's becoming commoner. Tuberculosis is with us. It's with us. It's been with us for a while. It is still with us, and I'm sure it will still be with us for a long while. So it's also there causing spine pain. Now, is there a correlation between aging, degenerative spine disease, and back pain? The answer is yes. The answer is this: if you live long enough, you will have back pain. It is not. Once you are standing up, upright, and you are sitting, you will have low back pain. Now, how early will you degenerate depends on your genetics and your lifestyle. It's not a singular factor; it's a combined factor. Now, how do you investigate? We are doctors. It is bad practice to send for an MRI first the patient that has low back pain. It's bad practice. So we are doctors, we should let ourselves know. The X-ray is still your first line of investigation. Now, if you now suspect that low back pain has a tumor relation or has nerve impingement relationship, then the MRI becomes necessary. If it is trauma related, your CT scan is good. If you think it's a tumor, go for your PET scan. More hospitals in Lagos are beginning to do bone densitometry. The only challenge that we have is that bone densitometry result is reported relative to the standard deviation of the bone density in your environment. So for anybody to report a bone densitometry report as osteoporotic, the person must tell us that he has done a bone density for majority of the population and he has a standard deviation that he's using to apply to take that decision. But oftentimes, taking the history, looking at the X-ray of the patient, you can infer reasonably that this person has an osteopenia is a radiological diagnosis. Osteoporosis is the one that is supposed to be with the bone densitometry, but you can infer that, look, it's part of the person's problem. Now, full blood count, ESR, CRP, those are basic investigations that we expect every doctor to order. If a patient has low back pain, you want to investigate, do X-ray, do a full blood count. You may be shocked. You'll be shocked at what you're finding from those things before you now go for the diagnosis. But if I ask, how many gentlemen here have written an investigation for PSA? Everybody's hands will be up. You understand? And that is the reality of our profession. It's a global trend. But what we are saying is that we should learn to love ourselves as much as we love our patients. That way, maybe we'll take more care of ourselves as much as we take care of our patients. The ETC there are several other investigations that you need to do that is relevant to the possible cause of that low back pain. Now, how do you low back pain in the aged? Prevention is much more than the therapy. That is the truth about it. Now, physical fitness. In Lagos, many gentlemen take walks on weekends. I wager most of them are not doctors. Most doctors on Saturday morning are going to the clinic. No, if I lie, if I say, okay, who are the gentlemen here? that walk on the streets of Ikeja or wherever, or go to stadium on Saturday morning? Raise your hands. Okay, I will have added the houses there. You see, but it's still in a minority. You understand? It's still in a minority. It's still in a minority. But if I ask how many gentlemen here and ladies have recommended exercise to their patient, everybody's hands will be up. So it's the same thing. Then we talk in terms of nutrition. The average medical personnel does not take breakfast. He's not a breakfast man. He's exiting early. But he's a dinner man. You understand what I'm saying? At the end of the day, he must eat after he has worked. But that work will not end till 10 p.m. You understand? So the same thing, is nutrition is different from food. I mean, are we nourishing ourselves? Are we taking appropriate supplements? It's we are talking about now, not patients. Then regular checks. I mean, we have agreed that we don't do regular checks. We only fill the forms. Now, if you don't follow those first 4, there's no way you can catch the early diagnosis. And the early diagnosis is what will prevent, it's cheaper. The early diagnosis is cheaper, and it will prevent bigger problems from occurring. So those are preventive measures, and when you make the early diagnosis, you apply proper therapy. There are quite a number of doctors who practice medicine but don't believe in medicine. They practice it but they don't believe in it. They write it, they prescribe it for their patients, but in their own clinic, for themselves, they don't take those drugs. They will tell you that, why should I be on drugs for the rest of my life? But he does prescribe antihypertensive for his patient, and he tells patient, make sure you take this every day. You hear me, sir? Good. So now, treatment. Very importantly, the treatment of low back pain, spondylosis, in the aging and in the aged is multi-professional. Is multi-professional. Without doubts, the medical doctor is sitting on the apex of the hill of practice of medicine. But the truth is that if those other layers were empty, that hill will collapse. If those other layers that were there before you sat on the apex, if they were empty, that hill will collapse. So you cannot do the work alone. If you want to have a result that will make your patient happy with you, you have to get others to work with you in the management of this patient. So who are the others? Apart from the physicians that are put in top, geriatric physicians, which is an area where we are lacking in our environment, seriously. We have all areas of medicine that are coming in now. Even subspecialization. People are subspecializing anyhow. But we have few people who can manage the aging population. And the aging population, despite our economy, is increasing. Now, orthopedic surgeons and spine surgeons, oncologists, when they are needed, pathologists, whether as clinicians you have respect for them or not, you cannot practice your medicine successfully without them. You need them. You have to work with them in the management of these patients. Radiologists and radiotherapists. Without them, that first investigation of X-ray, you won't get it. Radiotherapist, if he's not there, that your patient that has tumor will not get radiation. So you need them. Physiotherapists are your friends. In the management of low back pain, if you don't take anything away today, take that one away. Once you can rule out osteoporosis and tumors, and you are sure the bone will not collapse, your physiotherapist is your friend. He will make you look like you know all the work in the world, and he will do some of it. Nutritionists. Nutritionists are beginning to spring up in Lagos now. We're having nutrition clinics here, there, and yonder. I think as doctors, we should go once in a while and tell the person that doesn't know his job. You tell, what are you doing here? Yes, you don't know what you're doing, but you have taken information away. The person has given you information that will be useful to you, but you have left it your pride to say you know more nutrition. So you need them. Now, there are many more professionals that you're going to need. It's going to be on a case-by-case assessment that you decide who else you need to work with. Or just remember that you cannot do it successfully. Low back pain in those that are aging. Majority of your therapy, since many of your patients are going to come in early degenerative stage where they don't have neurologic deficits, they are going to come with osteoporosis. Some are going to come in early stage of tumor. Many of your patients do not need surgery. They don't need surgery. Surgery now comes into play in patients who have neurologic deficits, or patients who have structural deficits that you want to correct, or patients who have tumor that you want to either diagnose and start therapy, or tumors that have caused structural issue. That is where surgery comes in. And if the majority of your patients are at the early stage, your management is non-operative. So feel free to manage them, but remember, don't hold them beyond the point where they become operative, so that at that stage they don't run into trouble. Now, my take-home message: is there a correlation between aging and low back pain? Yes. Is there a correlation between aging and spondylosis? Yes. Is there a correlation between spondylosis and low back pain? Yes. Is there a correlation between the three? Yes. That's the first take-home. Note that that correlation does not mean, it does not explain the intensity. It does not mean that the older the person, the more the low back pain. And it does not mean that the more the spondylosis on X-ray or MRI, the worse the low back pain. It has nothing to do with that. You cannot generate a linear correlation between any one of them. But that they are related, the answer is true. Now, remember, at first point, not all back pain is degenerative, which is the biggest problem, the biggest mistake we have. So at the end of the day, by the time you are catching the ones that you should have caught, you have missed them from ab initio. Because the first thing you did was an MRI. You thought beyond the patient's speech. The patient is trying to give you a story. You are thinking way beyond. As doctors, usually we overtake you in our thinking, so you are overthinking. So overthinking will cause you to make an overdiagnosis. Now, regular checks. This one is for us, for we. So that we can continue managing our patients, we can continue living our lives and paying school fees, which is the main thing that drives doctors on, is school fees. Regular checks. That's the main thing. That's why doctors don't retire at 60. Doctors don't retire at 60. It's because of school fees. If you will see a banker by 40, 50, he has retired. He has money, he's retired in house. But he says, okay, but a doctor, you can't 60. Oh, to me. So you keep working. So you do regular checks. Nourish yourselves appropriately. Nourish yourselves appropriately. Now, lifestyle is key. Believe me honestly, amongst top professionals, doctors are the least that know how to enjoy themselves. It's not the. I know gentlemen that are here in this room right now that can afford to travel business class. I know them. And I bet when they're at the airport, all of us will queue in economy. As professionals, we know that. I know gentlemen that are here that can afford some vacation. But as far as they are concerned, once they're on vacation, the clinic will collapse. So no vacation. Guilty, thank you, sir. So, lifestyle modification is key. In fact, as a doctor, you need it. The profession is more, there are very few professions that take your time, your physical pain. Your patients travel with you to the house. They are with you when you are eating. They are with you when you are sleeping. If you are unfortunate and your wife is a doctor or a nurse, you are in trouble. It's double wahala. So you can imagine that much responsibility that has been put on your shoulders. For you not to have a break in a year. For you not able to say, oh, what, I've worked, let me just have 2 weeks of fun. Now, treatment is multi-professional.
Let's make that applause louder. And agree with me that Dr. Agm has done a very good work. Thank you so much. So we'll be making progress immediately. There will be a panel session for the ceremony of today. It's not that person that Dr. Yetunde will do that. Yeti, you are welcome.
Thank you so much. Good morning, esteemed colleagues. Would like to move on. My name is Yetunde Olujare. It's a pleasure for me to be here. I thank the Agpmpn chairperson, president, and executive members. Good to see you all again for that overview. I will move along to the panel session. That will be panel session 3, titled Age, Spondylosis, and Back Pain. We're correlating that with the manager. The consultant, neurosurgeon, and Luke. A round of applause for him, please. For this panel session 3, I'd like to invite the medical director, Crestview Radiologist, Dr. Agpmpn Lagos. A round of applause for him. Diagnostic Nigeria Limited, Agm. A round of applause, please. A warm welcome and another round of applause. Thank you. So we'll be moving along because of time constraints. All right, so finally we have some form of gender, all the genders are represented. Because I was wondering, where are the ladies? So thank you, ma'am, for being our powerful moderator for today.
Thank you very much.
All right, over to you. Thank you.
Thank you very much for the lecture that we had, Dr. Alim. It was very enlightening, extremely insightful, for many of us. So we'll go straight to our discussion, which is age, spondylosis, and back pain, correlation and management. So I would like to start with Dr. Ojo. We had the lecture and yes, spondylosis, and we do know that spondylosis is when there's degenerative changes in the spine vertebral disc. So
the common areas would be in the lower lumbar vertebra. So actually the commonest would be between L4 and L5. And that is because that is the most mobile. So when you sit, when you walk, when you run, the sacral bone is fixed. The next mobile one is L5, L1, and L4, L5. So when you look at most people with spondylosis, it will be between L4 and L5 in about 80% of them, because it is the most mobile. Thank you.
thank you, sir. We also there's also the case of cervical spondylosis. How would we bring that in?
Is another kettle of fish entirely. And the experience in the past few years is, until recently, we see the cervical spondylosis in the elderly group, 50s and 60s. But in the past few years, we're beginning to see cervical spondylosis in the younger age group. And I've seen few doctors, some students in the 30s and thereabouts. So, like Dr. Halmi said earlier on, it's a function of how you use it. We're beginning to see cervical spondylosis in the younger age group because we're tending towards using it more than we would have used in the earlier years. And that has been because of the mobile phone, social media. I once had a patient who would be watching movie on the mobile phone. 1 hour, 30 minutes and thereabouts. So yes, to answer the question, they both have the same etiopathogenesis, increasing usage, desiccating the discs, compressing the nerves. So they have the same pathway, and we're beginning to see more of them.
Thank you very much, Dr. Joe. Next question going to Dr. Ali here. You did mention that spondylosis can be age-related. I want to, would like you to also expand. Is it also sex related? Is it more, do we have more females, more males? You know, what will be the ratio?
Thank you very much. The reality of generation is that it's not gender related. But in different societies where women perform different services or roles, then you will find an increase in incidence. If you have a society where you have a lot of women farmers, women laborers, you will find more of it than the society where you have less of that activity. Now, in a society where you have sedentarism and you have women more in the corporate areas, you will find younger women as well presenting with features of early spondylosis. So it varies from the society where you are seeing most of these patients.
Thank you, sir. So you've just said something very critical here. In society where there's more sedentary lifestyle, so we can say that people that tend to sit down continuously it can affect them, true or false? If we were to just put it that way, true or false? I know in medicine there's no absolutes, but
when I was doing my presentation, I emphasized that if you are a long sitter, your discs will wear out faster. And there are other issues with women nowadays. The footwear is also not so back-friendly. That's the reality. It's going to create more lordotic pressure. So if you are not careful, you are going to have the problem in the posterior column.
There's a question here for everyone, and I particularly want to Dr. Ojo to take this. When it comes, Dr. Fatali, yes. Going to management of spondylosis, I would like to get your view. What would you say would be Dr. Alimi did talk about investigations and all that, so your viewpoint would.
Thank you very much. I think Dr. Alimi actually did a very good job when he was talking about the investigations. And he rightly said some of the things that we see now. When you are talking of back pain, the first thing or the first investigation that comes to your mind is to have an X-ray of the lumbosacral spine. At least to start with that. But like he said, we are beginning to see a deviation from that now, especially among the younger fellows. They tend to make MRI their first port of call. X-ray of the lumbosacral spine should actually be the first thing that you order for. And again, what do we see? It helps you to actually classify the type of problems that you're having. In most cases, it might just be ordinary muscle spasm, and then you can treat conservatively. And it's only when you think, oh, this is beyond what you can see, you think there are other structural problems. That's when you now go to MRI. But also, he said something. There are other related investigations that must be done. Because we should not lose focus and say that back pain is only due to lumbar spondylosis. No. There are some other things that can give you back pain. For example, in women, we do see a lot of them complain of back pain. And when you look at it, it's actually because of fibroids. And if you skip abdominopelvic ultrasound, you are going to miss the cause of that back pain. And there are a lot of people also with renal pathologies, especially renal tumors. They also have back pains. And I can remember vividly, there's a lady, a 40-something-year-old lady, and has been on treatment for 2 years for back pain. He's done X-ray of the lumbosacral spine like 3 times. He couldn't see anything. but the back pain will keep coming back. And honestly, we only said, okay, let's just take a look and do abdominal pelvic examination, ultrasound. And there was a huge renal tumor. Huge renal tumor. And she's been carrying this for 2 years. So when we are investigating back pain, we should take a proper history, and then we should tailor our investigation, not just to lumbosacral spine. We should investigate around it. For men, elderly men, PSA is very important. Of course, your blood picture is also very important. And this is what I would say, that you must follow the sequence. Do your X-ray, do other supportive examinations, and if you think you need to go ahead and do an MRI, then go ahead and do an MRI. Thank you.
Thank you very much, Dr. Fatade. That's
Yes, X-ray should be very high on the to-do list. But like you mentioned, history taking and physical examination would guide what I would do first. If I'm seeing a patient with low back pain, with weakness of the leg, I'll probably not ask for an X-ray first. I will be asking for an MRI. Probably more than I'll be thinking about the CT scan. If it's a straightforward back pain that has been on for a few months, yes, X-ray will do. But we have to understand that X-ray will only show the bone. And there are so many things that could be responsible for the back pain, just like you mentioned, which may go far beyond the bone and which X-ray would not pick. So if somebody had seen the patient and had examined physically, abdomen, back, reflexes, power, sensation, if there is any deficit, then it is no longer a straightforward back pain. At that point, an MRI is indicated so that we don't waste time. So the emphasis is on history, clinical examination, and investigation to support what has been found.
Dr. This question comes to you. Now, there's spondylosis, there's spondylitis. What's the correlation? You know, how, especially for us lay people out there, can we correlate? Can we say one shoots off from the other? What?
There are two different things entirely. Spondylosis is from the wear and tear as a result of aging and so on and so forth that Dr. Alimi had talked about earlier on. Spondylitis is an inflammatory process, just like tonsillitis, appendicitis, and so on and so forth. So it's an inflammatory process. There's an infection somewhere, which in this case is now perhaps in the disc or around the disc. So there are two different things. The investigative measure will differ. The management, completely different. Spondylitis, you need to rest and treat. Spondylosis, you have to encourage physiotherapy and so on and so forth. So we can't confuse them, although they may present together, or the presentation could be similar. In the first instance, back pain, the spondylitis will have fever. And the pain will be more on axial loading, on walking. Even palpating the region could give back pain. Whereas in spondylosis, maybe not. You may not find much when you are palpating or when you are moving. But yes, to answer your question, there are two different things.
The question goes to Dr. Fatade now. I know you have, when the doctors refer the patient to you, what are some of the red flags that you look out for that will direct you in the kind of investigations, because yes, it's one instance for the referring physician to say, I want an MRI done, and then in your own capacity, as a specialist, would you say, okay, no, you don't need an MRI? What are the kind of red flags? You would say, okay, rather than an MRI, let's do this.
Usually it depends on the source of the referral. If I see a patient from a neurosurgeon, I don't need to do any other thing. I assume he must have examined his patients. He must have done a thorough job before referring that patient. So there is no need for you to reinvent the wheel. If I see a referral from an orthopedic surgeon, the same thing. I know the patient has been properly examined. If I see a patient from probably a medical officer and I look at the history and it didn't tally with the investigation, that's when we begin to ask questions. But usually, you look at the history on the referral form and you look at what is being requested. If there's a discrepancy between the history and the request, that's when you say, okay, let me chat with the referring doctor and give him a call and say that, look, your history is this, the investigation you are requesting for is this. Are you trying, what exactly are you trying to look at? And that's where, we interact with the referring physicians. We don't just go ahead and do what is on the request form. We have to look at it and make sure that it correlates with the investigation that is required.
Thank you very much. Dr. Ali, should all cases be referred? All cases of back pain, should they be referred to, for example, Dr. Oju, Dr. Fatade, what would you say?
First of all, we are all doctors. If you refer all cases, then it will be overwhelming. And it's low back pain is so common a problem that if you decide to refer all cases, you also will not do anything. Now, your responsibility is to be able to identify cases that require more than just non-operative management. And that means that you have to refer them early. I will explain further. Now, if as a presentation, a patient presents to you with just low back pain, and you suspect that it is degenerative, and you cannot pinpoint where the pain generation is from, because the pain pattern in degenerative spine is not constant. There are 3 red flags in the spine. It's trauma, tumor, and infection. Their pain does not wax and wane. Their pain is there and it's constant. Once you suspect that, you refer to somebody else. If you feel that you can do further investigation before referring, then do so quickly and refer quickly so that the pathology is caught early. Not that you keep the patient, it gets complicated, then you refer. So back to your question, should all cases be referred? The answer is no.
Thank you very much, Dr. Ali. Mr. Ademola, would like your perspective as an equipment provider, would like to know from your end, right? The role of quality equipment in this case.
Thank you very much. I'm the business manager for Pacific Diagnostics, the sole franchise holder for Johnson & Johnson medical diagnostics products. The percentage, to be specific. The thing is, Dr. Alemi is there, and I'm sure Dr. Joe can attest to the fact that the gold standard, the products that we provide, are the gold standard for managing their operative needs when it comes to providing hooks, screws, and rods for example, scoliosis or kyphosis, and I'm sure they can attest to that. They also would attest to the fact that having the best products will give the best outcomes, and these are the things that will give that confidence that I'm giving the best. And since they want the best outcomes to come from their patients, you can only follow that up if you give the best materials. So what we also provide is that even if patients are referred abroad, they can't get products better than what we have here in Nigeria. So the beauty of it is that we have the expertise in terms of doctors here, and we also have the complement products which are the best anywhere in the world. And I'm sure they can attest to that.
Thank you very much. Take them one after the other. Okay, this question actually goes to, I would say, maybe Dr. Alimi. Please Please, what is the fate of long-distance drivers, i.e. trailer drivers? 2, surgeons who stand up operating for long hours. Do they suffer low back pain as well? Then surgeons with shorter hours standing. And most importantly, since you said that exercise helps, marathon and track and field athletes, how often are they visitors to the back pain clinic?
The reality of low back pain is this. Long distance drivers do have reasonable low back pain, very reasonable low back pain. Even though many of them may not come to the formal institutions because of economy, because of lifestyle, they are used to taking a few things on the road that will, a few non-recommended analgesia on the road, so they tend to manage until they run into trouble. There are quite a number of long-distance runners, long-distance drivers that cannot walk without support. You'll be surprised. Trailer drivers that cannot walk without support. So he doesn't even have control of his legs well enough. So he just puts his foot right on the throttle. And when he can lift it up, he manages to lift it up. I've seen patients like that. Now, surgeons, long-standing surgeons like Ojo.
Yes.
Now, the truth is that there's a price to pay. I'll be very frank with you, there's a price to pay. If you look, that's why when I was talking, I talked about the holidays. I emphasized that because it was actually for me than for any other person. Before we started the lectures, I had a discussion with Ojo. I know that he went on holiday. So he was asking me when I was going to go on mine. And he was chastising me. So that he would know that I heard him well. That was why I said it now. Now, it's a heavy price. I'm very frank with you. So when you do, we do 8-hour surgeries, standing, no breaks. When you do that, you must take breaks and holidays. Because there is this log for which you can do it. And if you look at the lifespan, the doctors and their lifestyle, you see that pathologists do better. Then you see that surgeons don't do as well as pathologists. Because, and among surgeons, the more physically demanding your work is,